Okay, so our main clinical base for the course of occupational diseases is the clinics of Scientific Research Institute of Labor Hygiene and Occupational Diseases of Kharkiv National Medical University. It is situated at Trinkler Street 6. You are going to have practical classes. You'll agree with your teachers about the time when they should start. You have 3 lectures, 3 practical classes, and you're expected to write a case history. As I have introduced, and there are 3 main topics through all over your course in occupational diseases. Introduction with dust pathology, then occupational disease caused by, in this case, physical agents, and occupational intoxications. At the end of this course, you are expected to pass the final control, consisting of basic level for satisfactory mark with 3 phases of practical skills evaluation, theoretical tests, and clinical tests. Then those who are who want to have a good mark, they are expected to successfully answer 10 clinical tasks with open formulation of questions. And those who pretend for excellent mark should pass oral conversation with a group of teachers, and you'll have appropriate questions or topics for discussion. Plus, you may have some additional points for your individual research work and some other um, some additional activities at our department. As I have already introduced, we have 2 main directions of our research in field of internal diseases of therapy and occupational pathology. And they could be combinations of chronic respiratory pathology with some cardiologic diseases, or maybe a vibration disease, and so on. You can see on the slide. The aim of our research, scientific research, is to improve the approaches to evaluation of mechanisms, to diagnosis of these diseases, treatment and prophylaxis, evaluation, maybe elaboration of prognostic models, and so on. Our own research is, or maybe it includes clinical hygienic. Just a few seconds, please. Just a moment. Все уже, да? Все, я. Dedicated to both the clinical hygienic aspect or central hemodynamics, clinical genetics, mechanisms of fibrosis, endothelial dysfunction, oxidative stress, and so on. As I have already introduced, there is no need to write anything in the chat. I mean, you may write some questions or so, but no need to register in the chat, because you have to fill the feedback form. You have received a link to feedback form with your emails, with your invitation to today's lecture. You have to register there. No need to write anything in the chat, okay?
Okay, teacher.
Okay, thanks. Good, let's continue. You may take part in your own individual investigations, analysis of data, and so on, and making reports at scientific forums, attending lectures, seminars, and so on. So our today's genuine topic, one of topics, is introduction or general issues. First of all, definition. What is occupational diseases in general? It may be stated as a branch, as a part of clinical medicine involved in investigation of diseases caused by industrial or occupational hazards, and therefore it is a group of diseases caused by occupational origin, occupational cause, related to occupational cause. In different countries, there could be different quantity of new cases registered annually, from 5 to 10 persons per each 10,000 workers. And it depends on many things. It depends on both intensity of influence of occupational hazards for one hand, and the condition of healthcare service in this region or in appropriate plant or factory or other place of work. Classifications. All the occupational hazards may be classified by the principle of etiology on group of different dusts or dust of different chemical components, then chemicals, physical agents, and biological agents, and a group of functional hazards. Overstraining, for example, functional overstraining. So 5 main groups and 2 additional, such as allergic and carcinogenic. The reason of making 2 additional, 2 extra groups was proved by the fact that some of dusts may cause allergic influence, and chemicals also may lead to allergic response, and biological agents as well. And same carcinogenic may be caused by different groups, representatives of different groups of factors. That's why it was decided to distinguish both of them separately, additionally. Again, dust, chemical, physical, biological, and functional, plus 2 additional, allergic and carcinogenic. There is such a pathophysiological peculiarity of influence of these agents that are listed on the following slide. There are 5 of them. First, multiple factor impact. Each time, at each working place, every second, every moment, there are multiple factors influencing on the person simultaneously at one and same time. But there is monoetiology of the disease. Each of occupational disease is always caused by certain factors, certain agent. And basing on this, we prove the occupational origin of the appropriate pathology. Then, each hazard has polytropicity, so it influences on different organs and systems simultaneously. Pardon? And therefore, as a result of this, there is polysyndrome manifestation. For example, let it be lead, such a chemical element. Lead influences on nervous system, on blood system, on cardiovascular system, and many others. And therefore, we observe polysymptomatic or polysyndromatic clinical manifestation from side of different groups of organs, from side of nervous system, and so on. There is a exceptional or maybe essential role of individual peculiarities of each certain organism, starting from the facts that some of persons are defended from this hazardous influence of occupational insalubrities, and regardless of the fact that they undergo the influence, they do not develop the disease at all, or not so um, not so advanced stage at least. And for other hand, there could be predisposition to the disease, some background constitutional peculiarities, or maybe some background diseases which predispose to development of the disease. You should keep this in mind always. So, multi-factor impact, monoetiology of a disease, polytropicity of hazard, polysyndrome manifestation, and role of individual peculiarities. The classifications of occupational diseases may be performed by different approaches. By specificity, we distinguish specific occupational diseases and non-specific or conditional. Specific, in turn, are subdivided into absolutely specific or genuine and relatively specific. What does this mean? We state that some disease is, or some occupational disease is absolutely specific or genuine if it can never develop in non-occupational conditions. It may develop only in occupation, in some certain occupation. Then, relatively specific, when some disease, um, by some conditions, it may develop in non-occupational circumstances, but anyway, it's very rare, and if it develops, it's mostly occupational. The example of absolutely specific, which develop only in occupational conditions, there are only two: vibration disease and a group of pneumoconiosis. In case of relatively specific, there is widened spectrum, like radiation disease, intoxications with different substances such as manganese, lead, arsenic, mercury, and so on. And there is a big group of the most of diseases. They are named non-specific or conditional. When, for example, dust or dust pollution of air may cause development of, for example, chronic bronchitis in population, not only in occupational diseases, but if this pollution takes place in working environments, if this dust is industrial, we state this disease as occupational. So it depends. Then, the other approach to classification of occupational disease by etiology is based on the fundamental classification of hazards. Occupational disease caused by dust is our today's topic as well. Occupational disease is caused by chemicals, or they also named poisonings or intoxications. Then, third, occupational disease is caused by overstraining. Occupational disease is caused by physical agents, and occupational disease caused by biological agents. There are 5 main groups, and there are 2 additional. Do you have any ideas what kind of additional diseases or groups of diseases they could be? Do you have any idea what 2 additional groups do we distinguish?
Carcinogenic.
Yes, we name it carcinogenic as hazard, but we name it oncological, right? Oncological in the clinics. And same for allergenic, or we also may name it sensitization, yeah, related to sensitization. And same for allergic diseases. 2 additional, allergic and oncologic. Thanks. Great. Then we distinguish occupational diseases by systems. It's natural distinguish principle, such as occupational diseases. It's important to note with predominant affection of what? Respiratory organs, blood, nervous system, digestive and hepatobiliary system, sensory organs, locomotor system, urinary system, And as you can see, some more systems left, but we do not distinguish any disease related to its predominant affection. There are cardiovascular, reproductive, immune, and endocrine systems, right? The reason why we do not associate any disease with predominant affection of these systems is probably in their um, integrative function, probably because they suffer more or less in each of disease, and we haven't found any specific disease with predominant affection of them. The diagnosis of occupational disease is caused, or maybe is based on very basic principles. And this slide, this table, as for me, is one of fundamental in all the course of occupational disease. If you understand it well, you'll succeed with the rest. So, when some person comes to us, or we have to evaluate some clinical case, first of all, we wonder about occupation. Occupation in present or even in past. Uh, if you have, if someone or some doctor has enough experience in the field of occupational disease, just exactly when he or she knows or gets an information about what exact profession, what exact occupation, in what exact occupation some patient has been working before, he already may suppose the most the most probable diseases which may get developed. For example, if some person, some worker has been working as electric welder, we know that he has to undergo, or he had in past, to undergo influence of welding aerosol, its dust, some fumes, its chemical and irritative influence, some forced position, posture, its overstraining, physical restraining, then excess light during welding process, then there could be unfavorable physical conditions like overcooling or overheating. There is a risk of traumatization, so there could be traumas. There is a probable influence of noise because sometimes they use emery machine to clean the surfaces they have to bind and weld, and so on. It helps. So evaluation of occupations and uh, revealing of this information in past in anamnesis variety is essential in the diagnosis of occupational diseases. The next step is getting information about duration of work, total duration of work or working experience. We take it from work record card or general occupational history, just ask the person or get from official documentation. And it's again important for us because some diseases may develop only as a result of prolonged influence of some occupational hazards, while others may develop suddenly just after one very short contact uh, with the insalubrity. Then occupational or maybe working conditions. Working conditions consists of five main aspects. First, what occupational factors this person has been underwent, right? Underwent in general. For example, as I told you on an example of electrowelder, it's I just made a list of them. For example, welding aerosol, overstraining, unfavorable climate, microclimate conditions, and so on. Then, second aspect uh, is excess light, right? Then uh, second aspect is intensity of influence, right? So if we tell that there is influence of welding aerosol, we wonder about exact concentration of different substances in working air. For example, we evaluate that the concentration of, let it be, iron compounds is 6 grams per cubic meter, the average concentration, of course. Can we evaluate exactly how much is it? Is it normal or not? Maybe not until we have the exact information what is maximum permissible. So first, what hazard is influencing, then with what intensity, then and what is maximum permissible concentration or maximum permissible level of it. For example, if we relating noise, industrial noise, and we know that at some working place the objective level of noise is, let it be, 50 decibels, and we compare with 80 decibels of maximum permissible level, we could evaluate that the probability of occupational deafness development is not so high. But if we reveal 80 and higher intensity of noise, 80 decibels and higher, the probability of occupational deafness is significantly higher. So we need fact of influence, intensity, maximum permissible level or concentration, then the exposure time. The fact is that different personnel, different workers may undergo influence of occupational hazards throughout all the working day or only parts of it. So it depends. And mm, let us continue the same example. Electrowelder. If this electrowelder is using emery machine, for example, for 10% of working time, and not even every day, the probability of development uh, development of the disease, of vibration disease, is relatively lower than uh, and if vice versa, he is conducting this welding process and influence of excess light for prolonged time, uh, it lasts for major parts of the working time, and therefore the probability of uh, for example, influence on the of the eyes and appropriate development of cataract or so is much higher than, for example, development of vibration pathology, right? Then the next aspect is occupational, and the final aspect of working conditions is prophylactic measures um, used to protect against development the disease. For example, if this welder has been using special welding mask or respiratory mask or uh, special gloves and protective clothes, if he has been following uh, basic instructions of uh, containing prophylactic measures such like uh, making periods of rest, appropriate defense against risk of trauma, and so on, the risk of occupational pathology is significantly lower than if he didn't follow them. And for instance, we also wonder about the quality of this protection. For example, one of protective approaches is periodical preliminary and periodical medical checkups. We wonder about the quality of them by asking these patients about what doctors of what specialties took part in the commission, this medical checkup, then what additional investigations has been performed, and so on. Unfortunately, sometimes and even often, we observe that the quality is lower than it is poorer than it should be. Then, occupational morbidity, the fourth point aspect of this evaluation in terms of diagnosis. Occupational morbidity is significant for us in terms of the prognosis that if we uh, already diagnosed occupational diseases in other workers from said places of work, and other worker from same place admits to us with similar manifestations, this helps us to prove the diagnosis, decrease the probability that there is again some occupational disease. Right? Умничка, молодец. Then we wonder about health conditions before start of work, during period of employment in some working place, and after discharge, if he or she has already stopped his work in some certain place. It's important for us because typically some persons are employed in relatively healthy condition, then gradually or suddenly some changes happened to their health state, and then they recover or not did haven't recovered finally. Uh, but anyway, there is some dynamics, right, of the condition of the person. Then the course of the disease. It's also essential for us rather often when, for example, we have to distinguish what kind of disease, or maybe the probability that some disease is related to one or other occupational factor or not occupational at all. For example, in one and same place, some persons which undergo influence of toxic substances may develop uh, such an irritative uh, bronchitis with irritative cough rather often, with expectoration of sputum and so on. And in case if this chronic bronchitis is caused by, don't write please your names in the chat. There is no need. Register in the feedback form. You have it in your invitation and emails. Um, and if, for example, chronic bronchitis is caused by dust, mm, more probably will have almost no or very slight clinical manifestations with very gradual uh, progression, with latent onset and very stable changes, with mostly not productive but atrophic changes in the mucous membrane of respiratory organs. Then the next step is identification of certain signs, manifestations. They could be specific, which may develop only in some certain disease and never met in other conditions, or typical, which may again met may be met in this disease or other, but there are rather often in some certain diseases, or non-specific at all. If specific signs help us to specify the exact disease, and typical group of typical signs also help us to be sure about exact disease. A sum of non-specific signs adjust the peculiarities of the case. They help us to um, detailize the diagnosis. What kind of form, what kind of course, what kind of phase, what kind of complications, and adjust our therapeutic approach as well, our treatment for this person. For example, the specific sign or specific criteria of the diagnosis of pneumoconiosis is uh, is evaluation of morphological substrate. It's granuloma, specific granuloma. For silicosis, silicoma, for example. While in our practice, we mostly do not need even to make a biopsy and take this piece of lung and evaluate the structure of tissues, looking for sericoma. It's enough for us if we have appropriate set of typical signs like diffuse bilateral pneumofibrosis, predominantly in middle and lower regions, and uh, plus we have very gradual development of the disease, lack of clinical symptoms. Then if we prove that this person has been exposed to dust containing free silicon dioxide in concentration exceeding maximum permissible concentrations, and this sum of typical signs plus non-specific like cough, dyspnea, cough is dry, dyspnea is inspiratory, pain in chest is diffuse, bilateral, associated with breathing movements. A group of all these, summarization of all these signs help us to diagnose the disease. Even sometimes we do not need to reveal the specific sign. In some diseases, we even do not have any specific signs. Then we have to exclude other cases, occupational or non-occupational, so perform differential diagnosis. And finally, we put the final diagnosis basing on maybe a decision of a group of experts. Usually in this group of experts, there are therapeutists, neurologists, and maybe some more, depending on the case. If the case is, for example, pulmonological, there could be pulmonologist or physiatrician. If it is related to orthopedic traumatologists, there could be orthopedists and traumatologists, and so on. So these are main aspects of diagnosis. Prophylaxis approaches or practice approaches to prophylaxis of occupational diseases. It's, of course, hygienic improvements of technological process. For example, dry mining and so-called moist mining, right? With uh, sedimentation of dust present in the air. Then hygienic monitoring with the evaluation of the exact concentration of some substances and so on. Use of individual protection and populational. Then a group of medical social measures like preliminary and periodical medical checkups, like uh, rehabilitation, physical rehabilitation, and so on. And of course, dynamic follow-up of each certain person, especially if some preliminary signs of possible occupational disease have been revealed. I advise you, so not just I advise, it's there are following best textbooks which may be useful for you in studying this subject. I advise you most of all our department's textbook. It's available free of charge in the library. You may take it. It's Occupational Diseases, edited by Kapusnik and Kostyuk. I was also one of co-authors of this textbook, and feel free to use. One of the best textbook all over the world is Rosenstock and Cullen with co-authors, textbook of clinical, occupational, and environmental medicine, and so on. There's a plenty of other publications. Of course, feel free to use World Health Organization website with appropriate branch of occupational diseases. The most maybe leading institution is National Institute for Occupational Safety and Health, situated in United States of America, but it is international, and so on. So let's make a break, and after break we'll have other topic with you. It's named dust pathology, pneumoconiosis, chronic bronchitis, and COPD. Now we have 10 minutes of break. Ну что, Зай, да? Старайся, потом мне очень расстроила сегодняшняя ситуация, что я плохо живу. Это же... Давай, давай, делай все. Мне еще нужно еще сейчас лекцию дочитать, потом встретиться. Давай, я поработаю. Бери следующее задание. Я сейчас просто... Ну, я понимаю. Стараюсь, я по максимуму, я с остальным помогу. Бери следующее задание.
Recording in progress.
Здравствуйте.
Приветствую, Алексей.
2 секунды. Хорошо слышно?
Да, вас хорошо слышно.
Спасибо.
Порядок. Записал вас.
TWO. 12. 12. So let's continue. I'm monitoring your registration for the lecture. And I have observed one question. Pathology in occupational health. It's literally on the screen. It's not clear what you are wondering for. If you by pathology mean a branch of medicine like pathologic pathomorphology, pathophysiology, and so on. So we have already discussed the 5 basic pathophysiological aspects of occupational pathology, and the rest is more specific for each certain disease. And while we'll discuss each disease, we'll answer these questions. If you have some specific question in this relation, please specify again. Write it in the chat or in the registration form. Let me check again if any new questions. No questions, no questions, nothing, right? So if you have, feel free to ask. Now we have the second part of our this lecture. It's dust pathology, right? Please register in the feedback form. The link is available in the invitation to today's lecture. 15 minutes before the end of the lecture, you'll get the link in your emails again. Maybe I'll do it for you now. Okay. One moment. Scheduled lecture. Here is the link to your feedback form. If you have already registered, no need to repeat. Only one time. Okay, let's continue. So, dust pathology. One of groups of occupational diseases caused by dust is a group of pneumoconiosis. The term pneumoconiosis comes from Greek pneumon, lung, conia, dust, and osis, chronic disease. It's a group of occupational diseases of lungs with predominant location in lungs, caused by prolonged influence of dust and characterized by the development of diffuse pneumonitis, which results in pneumofibrosis. Diffuse, bilateral, predominantly in lower and middle zones of lungs. Again, pneumoconiosis they are characterized by pneumofibrosis, located mostly in the middle and lower zones of lungs, diffusely bilaterally. Harsha, Sriedul, if you have anything to tell, please tell. Have any questions or so? Harsha. It was occasional. Good. By classifications based on etiology, we distinguish following groups of pneumoconiosis. First group, there is only one representative, silicosis. It is caused by free silicon dioxide or silica or quartz. Silicatosis, it's a group of pneumoconiosis caused by salts of silica acid. Silicase, right? Bound silicon dioxide. Asbestosis, cementosis, talcosis, and others. A group of carboconiosis. There are pneumoconiosis caused by carbon-containing dust. A group of metalloconiosis caused by the pneumoconiosis caused by dust containing then there is a hypersensitivity pneumonitis. There are also a group of diseases such as berylliosis, bicinose. So there are so kinds of pneumoconiosis which are characterized by significant development or intensity of immunological components in the inflammatory reactions in this fibrosis as well. Then, classification of pneumoconiosis by etiology may be also based on the level of fibrogenicity of dust. And by this principle, we distinguish high and moderately fibrogenous dust when the contents of free silicon dioxide is exceeding 10%. Pneumoconius caused by low fibrogenous dust, less than 10%. And hypersensitivity pneumonitis caused by dust or aerosol of toxicoallergic influence. We also distinguish pneumoconiosis by X-ray changes. We distinguish the phase of initial fibrosis, like a 0 stage, interstitial, nodular, and nodal. For instance, all my presentations have been attached to the invitation for today's lecture. They are also available for download, and I'm going to record this lecture and make it available for you on my blog, my personal blog at my website, and located on YouTube as well. Then there is continuation of this X-ray classification with detailization of changes in pleura and other X-ray changes, like presence of emphysema, like presence of signs of tuberculosis, and so on. The stage of pneumoconiosis is so the diagnosis of stage is based on evaluation of both X-ray changes, so morphological changes, and evaluation of functional condition, like ventilation function of lungs, like presence of complications, their severity, and so on. As you can see on this slide, at first stage, we mostly observe diffuse intensification of lung pattern, slight emphysema of lungs, mostly in bilateral in lower, maybe slightly middle parts of lungs, and enlargement of lung roots. They become more thickened, right? At second stage, all these changes become more expressed. They could be some deformation of heart shape as well because of inclination to hypertrophy of right ventricle and right atrium. And finally, at third stage, we observe decompensation of these changes with either expressed pneumofibrosis on the background of emphysema of lung or development of complications, maybe tuberculosis, maybe pleural effusions, maybe cor pulmonale, maybe chronic obstructive pulmonary disease or bronchial asthma with and so on and so on. You may see on the slide the sequence of X-ray changes from stage to stage, but again, on X-ray we might observe some light changes, while if we have in this patient significant functional disorders, significant complications with advanced stages, we will prove the higher stage of the disease. And we have some more approaches to classification of pneumoconiosis. So stages, first, second, and third. Then complications. There is a list of complications from respiratory to systemic. Lung ventilation disturbances, typically they are restrictive. Sometimes they could be combination of restrictive and obstructive. They could be also diffusive, not diffuse, but diffusive problems with diffusion of gases. We distinguish four types of development and four types of course. We state the development of pneumoconiosis when we diagnose it at first time. So we state the onset, the development is right like sun, acute, fast, slow, or late. Or if we already follow up the person and it is not first time when we observe, when we examine him, we formulate the course of the disease. It could be quickly progressive, slowly progressive, stable, or regressive. What are the diagnostic criteria of each of these types? Acute. We state the acute development if the onset of pneumoconiosis takes place within 5 years from the start of work. If it lasts for more than 5 years, up to 10 years approximately, we state it as fast development. If it takes even more than 10 years after start of work, we state it as slow development. The majority of pneumoconiosis have slow development. And finally, it could be such a situation when some person has been working for some time, then stopped working, has discharged from the work, finished it, and in 5 and more years, pneumoconiosis develops. In this case, we state it as late development. Then, similar situation for type of courses. If we observe that the progression of pneumoconiosis from stage to stage lasts for less than 5 years, we state it as quickly progressive. If it lasts for more than 5 years, from 10 years and so on, it's slowly progressive. Then, if there is no progression of pneumoconiosis to next stage for more than 10 years, we state it as stable. And finally, if there is involution of pneumofibrosis, we state it as regressive. And let us brush up the main aspects of characteristics of each of main, at least, representatives of pneumoconiosis. If you remember, we have groups of pneumoconiosis, so the first 5 groups. The first group has only one representative, it's silicosis, it's pneumoconiosis caused by dust containing free silicon dioxide or quartz. And there is some noise. Do you hear the noise? No need to write in the chat with your names. Register in the feedback form instead. Okay, let's continue. The maximum permissible concentration of free silicon dioxide is from 1 to 4 milligrams per cubic meter. In some cases, there is even up to 6 milligrams per cubic meter. It depends on the quantity or ratio of silicon dioxide in the dust, because in the majority of cases, it's not just whole silicon dioxide, it's only a mixture of different substances inside the dust. Then, the main industries in which there is relatively higher risk of development of pneumoconiosis in general and especially silicosis are mining industry, metallurgic, machine building, production of fire refractory materials, construction works, production of building materials, and so on. The average working experience enough for development of silicosis is more than 10 years in average. The pathogenesis of silicosis has at least 3 main components: mechanical influence of dust particles on the mucous membrane with appropriate irritative damage of the cellular structures, then colloid absorptive with the formation of free radicals and damage of tissues, again, but by chemical mechanism, immune component with cellular reaction, formation of granuloma, and finally we have diffuse fibrosis. If we manage to get a sample of the tissues, we may diagnose sericoma, it's specific sericotic granuloma. Here is the illustration how it works. Dust entering the respiratory organs, reaching the distal parts of bronchial tree and sometimes even alveoli, causes mechanical damage, formation of free radicals, and influence on immune system, causing inflammation, causing reaction of vessels, finally production of collagen fibers and fibrosis development, and a set of extrapulmonary changes. Here is on the slide an illustration of a microphotograph of coniophags. There are macrophages which have swallowed some dust particles. Sericoma on biopsy specimen. Clinical manifestation of typical silicosis is characterized by three main components is dyspnea, cough, and pain in chest. Dyspnea is mostly inspiratory, cough may be absent or if present it is dry, non-productive, and pain in chest is transient, bilateral, associated with deep breathing. In other words, it's connected, it's related um, uh, to rubbing of lung surfaces in pleural cavity, rubbing of pleural leaves with each other because of diffuse deformations of them. Then, on physical examination, we usually observe enlargement of chest, such as emphysematous deformation of chest, mosaic percussive sound, because there are locations of dull sounds above the accumulations of this fibrosis, and bang box sound above emphysematous cavities or regions. And rough breathing with possible dry rails may be also present. Of course, silicosis may be accompanied by bronchial asthma or COPD, and therefore appropriate clinical manifestation for these diseases, typical for these diseases, may be also present. And as well, there could be extrapulmonary affections like Kaplan-Collinet syndrome, dermatomyositis, and so on. On X-ray, we may reveal interstitial fibrosis shown on this X-ray, or nodular type of pneumofibrosis, more expressed nodular and linear. There could be nodal changes when there are big fusions present and nodules, right, tumorous form. Medical checkups should be performed annually. The specialists included in the commission, a group of experts for persons who are exposed to free silica dioxide, includes therapeutists, otorhinolaryngologists, and by indications, dermatologists, pediatrician, and oncologist may be also included. The investigation with this inside these periodical medical checkups includes X-ray, thorax, pyrography, basically, in addition to, of course, to basic tests, and contraindications to continuation of work in contact with silicon dioxide are dystrophic changes of upper respiratory tract, development of initial stages of pneumofibrosis. There could be respiratory tumors or not only respiratory, rheumatic diseases, and other conditions which predispose to development and progression of silicosis. And if first stage of silicosis has been diagnosed, the reasonable employment and invalidity group, the third group, may be applied. At second stage, there is definitely invalidity group. If it was complications, there could be even second group. At third stage, there is also mostly invalidity group, first or second groups. And maybe summary of aspects typical for silicosis. There is a risk of acute development. Silicosis is continuously progressing type of disease of pneumoconiosis. So even if we do our best with diagnosis, with treatment and prophylaxis, if it has developed, we cannot stop it. It will always progress. Asymptomatic course is typical for this kind of pneumoconiosis. Мне просто еще одну встречу. And silicosis is characterized by predominantly nodular type of pneumofibrosis, this formation of nodes, and a plenty of extrapulmonary changes like Kulineka-Planck syndrome. Kulineka-Planck syndrome is a combination of silicosis and rheumatoid arthritis, for example. So as soon as we have only 15 minutes left, let me highlight only main aspects of the rest of pneumoconiosis, and if we have time, the rest of dust pathologies. So asbestosis is pneumoconiosis caused by dust-containing asbestos. Its peculiarities is in the fact that, first of all, it is caused by such a mineral which dust particle have such a fibrous form, as you can see on the slide. You may see that the shape of each of dust particle is like a needle maybe, or like a fiber, and the size of these fibers may be 1 or 2 micrometers, very small, and they enter the respiratory tract, and some portion of them is left inside the mucous membrane. They may penetrate the intercellular regions or even inside the cells. And if they remain, they may cause a plenty of changes, like irritation of germinative layer and formation of hyperproliferation of mucous membrane, with predominant possible development of adenoma and adenocarcinoma, so tumors. And nowadays we are mostly faced with the problem of asbestosis in relation to tumors, to oncological pathology, to pleural effusions, to development of mesothelioma as well. So if we generalize the set of peculiarities of these kind of pneumoconiosis, we should state that don't write your names in the chat. It has no sense, no need. You have to register in the feedback form. How many times should I repeat this, people? Check your emails. I have automatically sent the invitation with the link to registration form. Good. So the peculiarities of asbestosis are as follows. Clinical symptoms precede X-ray findings. Even at third stage, pneumofibrosis is not so expressed as in silicosis. There is no inclination to quick progression. The severity of state is determined by complications. There is a high risk of cancer and mesothelioma, and there is a plenty of extrapulmonary manifestations like asbestos warts, and so on. Anthracosis, it's pneumoconiosis caused by coal dust. Maybe you know this mineral, you know this principles. So it's one of variants of pneumoconiosis. Let's focus on its peculiarities. First, the contact with dust during more than 15 or even 20 years is typical for these patients. If silicosis develops in 10 and more years, asbestosis also 10 to 15 years, anthracosis develops even more slowly. Then concentration of dust containing, of course, coal, should exceed maximum permissible concentration. The clinical manifestation precedes the development of pneumofibrosis itself. And the complication with bronchiectasis is highly typical for anthracosis comparing with other types of pneumoconiosis. And then the next type of pneumoconiosis is berylliosis. It's also sometimes named as sarcoidosis with known etiology. And please pay attention, have a look on the maximum permissible concentration of berylliosis. As you can see, it's several thousand times less lower than of silicon dioxide for silicosis, if you remember. Then, a part of a part of fibrogenic influence, beryllium causes toxic component of pathogenesis, sensibilization, carcinogenic, teratogenic, and it also is inclined to depositions, making depositions of it in the tissues in the organism. And maybe let me show some peculiarities of this kind of so Curtis test. There is a special test to evaluate the sensibilization to beryllium in patients, and if we prove it present, so it helps us to prove the diagnosis as well. The peculiarities of berylliosis include sharp asthenia, hyperthermia. There could be development of this disease even at low concentrations of beryllium in air of working area. Then the late development is possible. If you remember, the late development was also possible for silicosis. So-called Monday syndrome is a feature of this pneumoconiosis. By Monday syndrome, we understand that when some person has weekends, some weekend vacation period, after coming back to his place of work and having contact with the beryllium, his condition is worsening, while on other days it's not so expressed. Extrapulmonary granulomatous inflammation is typical for this condition with lymphadenopathy and so on, a worsening of wound healing, and of course, positive Curtis test. Okay, so if you have any questions, feel free to ask now. I will check if you have got any questions in your feedback form now. So you may ask your questions orally or type what is pneumoconiosis. There was a question, I have received a question, what is pneumoconiosis? I have just explained this, that pneumoconiosis is a group of occupational diseases caused by dust with which is characterized by diffuse pneumofibrosis, bilateral and localized, located predominantly in middle and lower regions. Pneumon, lung, and conius dust, right? All this chronic inflammation, chronic disease. So everything okay? Okay. So I don't have any questions, any more at least questions from you. If you would ask them now in chat. Let me check the chat now. I don't see any questions in the chat. Don't forget to register in the feedback form. You have received the link in invitation for today's lecture. You also have it's separately in your email. I was happy to get acquainted with you, to meet you. Thank you for coming. Waiting for your questions or any response or feedback in the form. Please, do you have any questions?
No, sir.
Thanks. So if you don't mind, we can finish for today.
Okay, sir.
Uh,
Thank you so much.
Take care about these presentations if you need. You may freely use them. Then, if you some of you are interested in collaboration, right, for medical scientific research, my assistant and I will check for this and contact you. Okay, if you have any urgent requests, feel free to write me by email and we'll communicate with you. So thank you. Good luck. Bye. See you next
Goodbye,
lecture.
teacher.
Goodbye. I hope that I have recorded this lecture, so I'll make it available on my blog and YouTube channel. Thank you.
Thank you so much, sir. Good day.
Thanks. Same for you.